Hello and welcome to the Spine Nerd Podcast. My name is Dr. Brian Joves, and today I get to be joined by Dr. Jason Kung. Welcome back, Dr. Kung. How are you?
What's up, guys? I am excellent. Thanks for having me.
Oh, always. So I was having a conversation with a group of docs that sits on one of their communities for one of the HMOs locally here,
Uh-huh.
and it was brought up that a lot of people weren't aware that for California there was a new release by the medical board last year about prescribing opiate medications, or actually just chronic medication management for patients living with chronic pain. And so a lot of people weren't aware of it. A lot of people were questioning some of the things that had come out from it. And so I thought maybe it'd be a good idea for us to chat about it. What do you think?
I think it's a great idea. I didn't know. I was one of those people that didn't know until you brought it up to me. And obviously, most people know about the federal changes to the opioid guidelines, as far as the CDC guidelines. But I guess in California, there's a specific one for us. And since we both practice here, I think it's very important to go over.
Yeah. Yeah. So basically, it was written and published last July, so July 2023. And it was an update to 2014 guidelines. And so, kind of timing pattern makes a lot of sense with the CDC guidelines, as you were saying, in terms
Hmm.
of following California. I think kind of just followed suit with what the CDC had been publishing and promoting. But I think it's relevant here in California because California came up with what's been called the Death Certificate Project, which was something that the board was utilizing over the past few years in an attempt to really try to focus on reducing the opioid prescribing, with the hope that that was going to be able to address the opioid-related overdose problems. And
Hmm.
so, I think anybody who's been in California or practiced in California or even read about California is aware that the California Medical Board has, done a very, some would say, aggressive job of going after physicians that they didn't feel were kind of living up to the standard of care and being able to care for patients as well as they would like for people to care for their patients. Um,
Hmm.
but California has kind of gotten to one of the lowest opioid prescribing rates in the country, um, and has continued to reduce its prescribing rates. And I think the California Medical Association, just as with many other medical associations, continued to just put out that, the surge in overdose deaths was not related to prescribed medications, but was because of illicit drugs. And I think this is something that, anybody who prescribes scheduled medications is aware of.
Hmm.
But it was, something that I think, the CDC obviously had to address a couple of years ago. And so the California Medical Board was asked to be able to do that as well. And I think one of the things that the CMA was trying to get the California Medical Board to do was to recognize that their death certificate project actually contributed to physicians being very reluctant to treat these patients, which, from the California Medical Association's standpoint, was a really important thing because obviously, as I think anybody who treats patients with chronic pain is likely aware, a lot of people don't want to treat those patients. And there's a lot of people who even do what we do that don't prescribe medications to these patients. And a lot of that is because of the fear of the medical board, particularly here in California. So
Right.
for, that was, I think those are the areas where the CMA was trying to push for these updates. And I think those are the reasons why it's so important that the California Medical Board kind of did eventually kind of come through with this last July.
Yeah, I think it outlines everything pretty clearly from the moment you see someone, you see a patient, how you're supposed to kind of examine them, document everything, whether you decide to start a controlled substance like an opioid medication, it goes over that. Then it goes over the tough conversations where things aren't going as planned, whether there's aberrancy or if there's just lack of efficacy. And it kind of has a lot of nuance as to how we should, as providers, treat these patients in a compassionate way.
Yeah. Yeah, and I think as the CDC tried to do with their updated guidelines a couple years ago, I think the focus is really on the patient, right? And being able to say,
Mhm.
okay, physicians are trained and have the autonomy to be able to do things that they feel are the most appropriate to help the patient. And every patient is an individual. And so being able to use arbitrary things like or um,
MME.
morphine equivalents as a kind of a guidepost of saying everybody needs to be treated exactly the same is not what physicians in general and most medical associations have been trying to vie for.
Right.
All right. So
Yes.
in the idea of being able to create these new guidelines that are a little bit more patient focused, we'll just kind of run through. I think because like you said, I think they did a very good job of kind of hitting a little bit of nuance at every step along that path. From the very beginning.
Mhm.
So their guidelines kind of starts with the patient evaluation and risk assessment. So kind of going from the very beginning and looking at the different risk assessments that they felt are the most appropriate to be able to see patients beforehand, assess their risks with substances, as well as understanding kind of their functional limitations and kind of relying on validated measures to be able to look at
Right.
these aspects.
Yeah, I think it's important to have these, I mean, there's mention of the PROMIS, PROMIS, pain interference scale, the brief pain inventory. Those are nice kind of standardized ways for us to evaluate patients with pain.
Mhm.
Personally, I always like to try to get as concise of a, 3 or 4 sentence, just, what is their pain like, the quality and intensity, when did it start? And really just trying to get into the detail of, what makes it better, what makes it worse. And that's going to help with eventually coming up with some sort of diagnosis, or if we don't know what the diagnosis is, at least putting you on the path towards trying to find something.
Yeah.
Um, they also looked at, you need to also assess for the risk for opioid misuse. Um, there are some mitigation risk mitigation tools. Looks like they have the TAPS, TAPS, or SOAPP. I'm not too familiar with the first one, but I think these are just some tools that you can integrate into that new patient visit to look at, what risk they are for opioid misuse.
Mhm.
That all plays into the factor of whether they're going to be appropriate candidates for opioids, because as we know, some patients are, and some patients, may be at higher risk, and that's when, the clinical judgment needs to come in, just and the individuality of each patient encounter, each patient needs to be put into play.
Yeah, definitely. And then they go on to talk about, establishing a diagnosis, like you said,
Mhm.
or at least, creating a good differential of understanding of what's, possibly going on with the patient. And I think the next part is one of the, I think, important changes that, might be a little bit easy to overlook, but it says exploring non-opiate therapeutic options, where previous guidelines said must have tried and failed this, and this before thinking about opiates.
Mhm.
This gives some room for the judgment of the clinician, right, of the physician to be able to assess the patient and to be able to feel like, okay, I think that the risks of this treatment and then the potential benefits and weigh those accordingly and be able to make a clinical decision, right? And I think that's, you know, a lot of this is about trying to give the some practice autonomy and treatment autonomy back to the provider. So I think this is it's a small section, but I think it is one that is a nice change because it is giving some power back to us as clinicians to be like, what, when in my assessment of this patient and understanding what's going on with them and my assessment of their
Mhm.
risks, I think that the potential benefit of this treatment outweighs these risks, so this is an option for
Right.
patients.
Yeah, as interventionalists, obviously we like to see this two paragraph section expanded into, 2 pages, going over every single type of minimally invasive spine procedure that we do. But I realize this is not really the place for that. But it's nice to see that they've at least made that part of the treatment. Usually when I describe to patients, there's a circle. We try to treat pain multiple times. It's not just a linear path.
Mhm.
Looks like in the past that was like that.
Yeah.
Um, it just kind of just brings up situations where patients are referred to us and for a specific type of procedure, but just quickly going through the medical history, you see that, I mean, there's end stage, osteoarthritis in multiple joints, so no matter what targeted intervention we do, overall, the patient's pain is, you know, should be better, but there's so many other pain generators that's when you start to, consider, maybe even using opioids in conjunction, but
Yeah. No, for sure. I mean,
that's what I thought of.
yeah, I think that's a really kind of reasonable patient. And I think it's, it does, like I said, for better or worse, giving the ability for the clinician to make an assessment and choose, right?
Mhm.
And just like you said, getting away from that kind of just stepwise manner, and I think for a lot of patients when they're coming in, I like to give them the spiel about these are all the tools that we have for you. And then
Mhm.
kind of acknowledging like a lot of times to address the pain, it's going to require many of these things, right? We're going to get you working with physical therapy. Yeah, we're potentially going to be looking at medications and procedures and maybe acupuncture and maybe this, and like having a lot of those tools kind of working simultaneously to be able to affect the patient's life in the most efficient and effective manner possible.
Yeah, one line in here really stuck with me. It says, "Pain relief is important, but it is difficult to measure objectively."
Mm-hmm.
And when I read that, uh, it's very true, especially when we do, like various types of diagnostic injections. You see the number, and you want the number to go down by 80%. But the number's not quite there, and then you ask, "Oh, what else did you notice?" "Oh, I was able to do X, Y, and Z so much better. I was able to do this, that." So then you're like, it's tough to get to the 80%, but that's basically what that sentence was saying, right?
Yeah. Well, I think that flows really well into kind of that next phase, right? Where the
Mhm.
next thing that they're talking about is the treatment plan and objectives. And obviously, as with everything that we do in medicine, right? They want us to be able to say why we're doing things, explain the rationale behind it, that we, obviously talk to the patients about these different options, and this is the one that we felt was the most appropriate. Um, but it also does acknowledge that, for uh, effective pain relief, you can have maintain function as well as obviously we're all aiming for improved function, but and on an ongoing assessment, a patient being able to maintain function as opposed to declining function over time is a win, right? And I think that
Right.
that's a difference in, like I said, small changes in terms of how they're describing it. But I think in the way that we actually think about this and the way that we actually treat patients, that's a big difference, right? If we can do things, medications or procedural or otherwise, that can actually maintain their function when otherwise, this pain would have, interfered and caused them to have a significant functional decline. Those are, very valid and worthwhile, you know, measurements that, and makes a big difference for patients' lives.
Definitely, definitely. The next section, let's see, the next section after this is, well, I mean, here after treatment plan and objectives, they go over patient consent, pain management agreements. So, they give hyperlinks to various types of pain contracts
Mhm.
here. And I think that's also important to have in, the first visit, and even having a conversation about what it means. I have patients asking me, I'm not here for medications, right? And I totally get that. And if the treatment plan that we come up together with is mainly interventions, then we kind of focus on that. But there are cases in, down the line, whether it's the treatments failed or something else happened, then we do need to kind of revisit with possible opioid medications, and that's when that agreement comes into play. So some examples are there if you look on page 9.
Yeah, and that's I think one of those things that as we're trying to figure out how to work with patients and trying to figure out how to be able to to help them, we do have to. Sorry for anybody who's watching on a video format. My littlest son just decided he wanted to come hang out with me, and that's why I'm laughing and not being able to pay attention to what we were just talking about.
Yeah.
Um, but yes, I mean, I think making sure that people do understand the idea of what these contracts entail, right? Whenever I talk to primary care doctors, I think a lot of them don't fully understand that. And I think that's one of the big things that people have to be able to truly understand is uh, is that these contracts are really, really important. And we
Hmm.
have to be able to have them documented well, because it protects the patient as well as the practitioner. And so we have
Right.
to kind of be able to just keep rolling with that.
So the next section is initiating opioid trial. Um, and I think the takeaway here is go low and slow. The other way you could think about it is slow, smooth, smooth is fast. So, um, they are saying that, the cures needs to be checked at least within 24 hours before prescribing anything for the first time. Uh, and yeah, just really going with a short acting opioid at the lowest dose uh, that you deem fit, and basically going up as needed and having frequent revisits to assess for the progress from it.
Yeah.
Yeah.
Yeah. And I think that's one of the areas that, I want to make sure we also point out, right? That ongoing
Mhm.
patient assessment portion, right? Where you're continuing to monitor, continue to follow up, continue to document, most importantly, right? Being able to document
Mhm.
that patients are, maintaining their function, getting functional improvement, tolerating medications, taking them as prescribed, doing all of those things, the 5 A's that everybody should hopefully know by this point that's interested in any controlled substances, because that ongoing assessment is what's really going to keep both the practitioner and the patient safe, and making sure that we're addressing things as they come up appropriately, and making changes as is necessary to be able to help them to achieve that functional goals that we're going for.
Yeah, and then going back to the morphine milligram equivalents, for here, what stood out to me was similar to what the CDC had put out in their new guidelines last year was the 90 morphine milligram equivalents uh, is not meant to be a kind of like a hard stop or some sort of red line. And once you cross the red line, then all sorts of other things happen. I mean, the only red line here is that it's required to have naloxone if it's greater than 90 MMEs. But besides that, uh, just proper documentation. What's the reasoning for it? I think they made that pretty clear there.
Yeah. Yeah. And so, I mean, I think those are, some nice updates that are consistent with where the CDC has been kind of pushing things, and kind of continuing to evolve it.
Hmm.
I think there's some discussion in the document about buprenorphine, and kind of talking about utilization of buprenorphine in patients with chronic pain, as it's now been approved. So it was not approved for
Hmm.
chronic pain the last time the guidelines were written. Focusing on that as what's currently deemed to be a safer alternative if we can get patients fully onto a buprenorphine product. And so I think those the more people know about it, the more people are aware of
Yeah.
it. I mean, I think the first time that we did a buprenorphine episode was like 2018. It was a little bit early in the process of the awareness. I know as over the years of prescribing this medication, it went from something where most people didn't know what it was, or even, I think there was still a lot of kind of gray in terms of its utility in patients with chronic pain, even perioperatively. I think there was a lot of gray early on. And thankfully, as more and more studies have been published and more data has been produced, we understand, the safety, the efficacy, even within the perioperative period, to be able to
Hmm.
continue appropriate treatment with these patients, and kind of making sure that they're able to stay on a tool that, for a lot of patients can be really helpful.
Yeah, it probably deserves its own episode here, but yeah, I won't get too much into it, but cost sometimes can be a limit to some patients, and that's unfortunate. When you see that in our society, that access to a potentially improved analgesic, safer uh, medication is limited because people can't afford it, and it's a shame. But we won't get into to
Yeah,
that too much.
that's a soapbox for a different day.
Yes, and I'll step down from my soapbox. Thank you.
But yes, not that any of that what you just said is not a reality of what we kind of go through on a daily
Yeah.
basis. But um, yeah, and then kind of along the lines of just continued monitoring, right? Obviously, going through the cures and the urine drug testing, they
Hmm.
mention pill counts as viable things to be able to do, and then it does walk through tapering and situations
Hmm.
for kind of discontinuing opiate therapy, which I mean, at least my read was kind of pretty standard with I think what most people are accustomed to at this point. Not sure if there was anything that stood out to you that was kind of game changing or different there.
Nothing really. I mean, there's an actual guideline that was been published by the HHS specifically on tapering. So I didn't know that. I didn't read into that too much though. But yeah, I think uh, generally the themes were, slow taper is going to be better tolerated by the patient than a fast taper. Um, I think, the one exception is that, which I think they talk about later in the paper, is that, if there's a serious risk of or known for medication diversion, then a taper's not need, taper's not really needed. But that's a special exception there.
Yeah. Just kind of on that note of diversion
Yeah.
versus somebody abusing
Hmm.
the medications or trying to take it inappropriately. They have a paragraph in there that does kind of talk specifically about it and actually the need for discussing with your medical malpractice and legal counsel. I don't know if
Oh
you picked that
yes.
up, but
Yep.
they said if it's if you're discontinuing because somebody's abusing, it may be worth talking to your medical malpractice. But if you're discontinuing because there's a concern of diversion, you don't need to.
Hmm.
Which I don't know. I don't know that I ever would have thought about the differentiation of that with
Right.
talking to your malpractice insurance or anything like that. But I thought it was a very interesting thing for them to kind of in a relatively concise document to be able to take up a
Yeah.
paragraph with that conversation.
Hmm. And yeah, I think they also, which has also been echoed again from the CDC guidelines, is that physicians can be held accountable for patient abandonment if you discontinue medical care without allowing for adequate provision for subsequent care. So you gotta have a plan B. You can't just kind of just close up shop and not give any sort of recommendation for anything. You have to do something.
Yeah, yeah, which has been made, and for better or worse, unfortunately, we still do see some cases where there are, practices that seem to kind of fall into that realm where they do
Hmm.
have, for one reason or another, do decide to just tell the patients they can no longer do this aspect of their treatment for them,
Hmm.
and best of luck in terms of being able to find benefit for those patients. Um, let's see. And then, I mean, as it goes forward, it kind of goes into some of the kind of special circumstances, like you said, kind of talking about, a lot of the, different things, acute pain, cancer pain. I thought one of the kind of interesting ones was legacy patients, patients who have
Hmm.
been
Yeah.
on high dose opiates for a long, long time and have been relatively stable and, obviously who have been appropriate with those medications. It did advise caution in being too aggressive with tapering these patients,
Right.
which I think any of us who have, tried to help people who have been in that situation before, who have been on very high doses of opiates, it's tough, right? I mean, obviously the body gets very acclimated to those medications,
Right.
and I think it can be very challenging to be able to be at, you know I don't even know if aggressive is the right word. I mean, but it can be tough when you're, even taking very, very slow steps with these patients can feel very challenging because it's tough, right? They've been on them for so long.
But but when it's done right,
Yeah,
it is people are so grateful
100%.
because sometimes it's almost like the not to say that people were treating patients wrong. It was just a different time, but
Mhm.
it's almost like they can finally see, or they can like step out of the room and finally see a whole world out there. It's um, when you change someone's medication regimen that they've been on for maybe even a decade or more, and even reducing it or changing to something else or do a procedure, or usually a combination of all of them, it can be very rewarding for the patient and also as the physician. So
Yeah. Yeah. And for anybody who is maybe new to that role or, or finds themselves in that role again and hasn't done it for a while, I mean, I think making sure you're very upfront with the patients. I mean, I, try to tell patients that in that situation, that we're going to try to work with and try to help them through. I'm like, look, generally speaking, the first bit that we're working together, it's going to be really tough, right? I mean, those first few months, depending on the patient, potentially the first year or so can be pretty challenging as you kind of slowly start to make those steps. Um, but man, you're right. I mean, as you get to once you turn the corner with those patients, it can be absolutely life changing. And
mhm.
the maintenance of function that they felt they were getting with
Right.
opiates turning into actual increased function down the road with those changes happening and the changes in medications, the procedural interventions, all of that. I think that obviously I think, for you and I, those are the things that we live for is being able to help make those big changes for people. But yeah, I think it's a very challenging patient, but it is also
Mhm.
an extremely rewarding patient.
The other section for the special population, I think, was for concurrent benzodiazepines. The first sentence, basically says exercise caution, right? So, as you know, the use of both of those medications together can increase your risk of respiratory depression and overdose. So you got to have a very uh, frank conversation with the patient, going over the benefits and risks. They did kind of mention an example, would it be appropriate in someone with severe acute pain that is also on a stable long-term low dose benzodiazepine, that, you know, clearly that's a little bit more on one side of the spectrum, but um, that's something to think about that, when people are on both of these medications, it's definitely a higher risk. You need to discuss those risks with the patient in a very straightforward way. This also leads that if there's a patient that's on both of these, then naloxone is, I believe it is required. Um, as long as it's within a year that the last benzodiazepine was dispensed, because some people take this really as a PRN very rarely, but if it's someone that's regularly on a benzodiazepine, and you're starting them on a opioid medication, they need to have naloxone. The other requirement for naloxone is greater than 90 mmes, as we alluded to earlier. And then the third one is basically kind of clinical judgment, right? If you think that they're at a higher risk for overdose, they should have naloxone at home.
Yeah, and just for thoroughness sake, for anybody who is out there, I mean, obviously, naloxone at this point is a medication that um, does no longer requires a prescription,
Mhm.
but is something that I think even if somebody's on a very small dose of opiates, is a pretty simple thing to be able to just have them to be able to have on hand, because it is a very in the grand scheme of things, a cheap intervention for to be able to make available that can really help to keep people safe.
Mhm.
Um, and then I think the last one that I kind of wanted to point out was telehealth. They brought up just because telehealth is so pervasive, and I think this is one of the things that our practice has really tried to do over the past year or so is really decrease the amount of telehealth. Obviously it's there as a tool, and that's exactly how it was written. Telehealth is a tool in medical practice, not a separate form of medicine. So the
Hmm.
words that they state are: the law states that prescribing without an appropriate prior examination and a medical indication is unprofessional conduct. And so, I think that, is basically speaks for itself in terms of how I feel about it. I think, obviously in certain circumstances, telehealth may be necessary for somebody who has trouble being able to get into visits on a consistent basis,
Right.
with mobility issues or the like. But generally speaking, being able to, have an appropriate examination on a consistent basis is, what is considered the standard of care. And
Right.
I think people should be aware of that and hopefully practice that.
Then at the very end, they have uh, there's a sample termination letter, sample discontinuation of opioid form, treatment form, and then just kind of like a very basic sample HPI, uh, kind of just outlining some of the things that we already talked about. Good documentation. My pain fellowship director really was uh, focused. Most importantly, was documentation, and as much as I would be maybe irritated wouldn't be the right word, but getting phone calls on Friday evenings about my documentation from the day, as much as that was disruptive for me during that time, it's really taught me so many lessons moving forward. So, Dr. Brenner, if you're listening, thank you for all the wisdom.
Yeah, I mean, as somebody who sits on a peer review committee and has had to look at a lot of these cases over the past 5 or 6 years, however long I've been on that committee, um, man, the thing that gets just about everybody is the documentation, right? I mean,
Mhm.
yes, there are some cases where uh, the medical decision making is potentially questionable or maybe outside of the lines of community standards. Um, but most of the time it is documentation. And so just to kind of echo that, it is
Yeah.
such an important part of making sure that you're, keeping yourself safe while doing the best things for the patient. And, it just helps, right? Because I mean, obviously, good documentation lends to, if something happens to you as a practitioner, that somebody else can kind of pick up because they can understand where you were, what you're thinking, and why you were doing the things that you were doing. 'Cause, we've all been in that situation where we've taken over for our seen a patient taken over a patient that was sent from somewhere else or something along those lines. You're not really sure what's going on, right? And so good documentation just helps with those handoffs for patients and
Hmm.
keeping them moving the way we want to.
Yeah. So uh, this guideline was, can't believe it took me almost a year to find out about it, but it's something that I feel like everyone that prescribes opioids in California should give it a read.
Yeah,
It's not dense. I mean, we breezed through it in, I don't know how long we've been talking for, but it's a light read. Okay, it's not deep dives or anything, and it really sets out kind of what they feel like is a standard of care. So I think it should be important to go over.
yeah, and not just California, but I think everywhere. I think there's really good
Right.
takeaways. I think that last page with just some nice ways of being able to kind of checklist items or proper ways of being able to document good things for being able to just care for these patients wherever you may
Mhm.
be. So I'll link the document in the show notes just so everybody has access to it. So you don't have to go looking searching for it online, or particularly if you're not in California and may not know how to navigate the California Medical Board's website, we'll make it easy for you. But yeah, I mean, I think we did a pretty good job of going through it. So I hope you guys learned something. And Dr. Kung, any closing thoughts on the opiate guidelines, or maybe just in general on kind of the state of um, you know medication management in the pain management
Yeah.
world in 2024?
Yeah, I mean, I guess the only thing I've been able to appreciate now that I've been in practice for a few years now is, we are the experts in pain management. So if you're an expert guiding a needle with fluoroscopy, you should also be a pretty well-read or expert in management of opioid medications, because it's challenging. I mean, even you're reading this guideline, you go back to clinic on Monday, and wherever you are in California or United States, you're gonna have challenging patients. And when, if you're not a trained pain management provider, then you would refer a patient to that person in your community. And so I think if you're out there, even if you don't, your practice doesn't prescribe pain medications, I think you should have some understanding of at least this, and be able to even do like a consult for a patient that's struggling and is being referred by primary care, or even just doing like a curbside phone call to PCP, and just kind of just help clarify some things, and just help ease the challenge sometimes, uh,
Yeah.
for
Yeah.
PCPs and other providers.
Yeah. I think I have probably a little bit stronger feelings on that topic than you do, but
Yeah,
I don't want to make anybody mad. Uh, but yes, I mean, I obviously, being aware, being able to at the very least, understand it, be able to give an opinion, be able to help the primary care doctors. But yeah, I mean, I think, we've alluded to this before on the podcast. We are the specialists in this realm, right? Our job is to be able to help these patients, and there's enough time spent by medical associations and medical boards and the CDC on these medications uh, to make you realize that these aren't things that you should be doing if you don't understand them, right? And so,
right.
we don't leave, you know, um, chemotherapy to primary care doctors. And similarly, I don't know that
Hmm.
we should leave, managing some of these patients to the primary care doctors. That in general, right?
Hmm.
I think being able to be there and supporting them, and at the very least being able to offer some a good opinion with some from the expert level is what's needed and what's necessary
Yeah,
to be a well-rounded pain physician. We all love sticking needles and things, but this is the stuff that I think this is the stuff that really separates you in the eyes of the primary care doctors, right? Being able to help them when they need the help. There's
exactly.
a lot of people that can stick a needle somewhere. Obviously, I like to think that we do a fine job at that as well. But when the primary care doctor's in absolute need, it's not usually because they can't get somebody in for an epidural.
Usually not.
So, yeah. So I hope you guys learned something. We'll link this once again in the show notes. Dr. Kung is officially on LinkedIn. Please go say hi to him there so that you can grace his presence in the LinkedIn community and start to be able to build a great network over there. I think that tends to be where a lot of pain medicine docs live these days, and as far as the social media landscape is concerned. Um,
Yeah, yeah, it's
so
been great. It's been great to get back on some form of social media. That's probably the closest. That's probably the most active, even though I don't really post too much. But yeah, I feel like I got my finger on the pulse when I'm on LinkedIn now, with
yeah,
pain at least.
yeah, I think the community does a good job there of being able to show articles coming out, new guidelines that are being published, and so good place to be. If you want to try to convince Dr. Kung to do some dances on TikTok, you start by following him on LinkedIn, and then you could tell him there, and that'll be the way to get him there.
You can also start by hitting subscribe. Wait, is it here or is it here? I'm not sure which one of those.
Yeah, it'll be in one of the corners. But yeah, subscribe to the podcast. Share this with your colleagues. Share this with your primary care doctors that refer to you. This is just as important for them as it is for us. And yeah, we will be back soon to hopefully keep providing some value and helping people understand this crazy thing that we call pain medicine. Have a good
See you
one,
guys.
everybody.
Bye bye.